Okay, thank you very much. I'm very glad to see you at least online and presenting our results of graft infection. I can't do anything. Sorry. Okay. I have no conflict of interest. We performed a retrospective single-center observational study. Included patients with thoracic graft infection. Last 6 years, we included 31 patients, 5 of them from another clinics. In the last 6 years, we do more than 1,000 aortic cases. The mean time between prior operation and manifestation was 3 months in our investigation. The patients were divided into groups, graft removal or graft preservation, depending on surgical strategy. You see the graft removal was with replacement in situ or extra anatomic bypass with homograft or antibiotic impregnated prosthesis. Graft preservation with aggressive debridement, antiseptic irrigation, negative pressure wound therapy, and vascularized flaps with omental flap, muscle flap, thoracodorsal or pectoral flaps. In most cases, we use combination of methods if we do preservation of graft. Sorry, I can't. Next slide. The primary open surgical repair was performed in 17 cases, 9 hybrid and 4 endovascular repair. You see that the group removal, 50% of patients with sepsis. You see, and group preservation, most of our patients with wound infection. Median follow-up time was 4.4 years. Primary, secondary endpoints you see here. We performed multivariate factor analysis of reinfection and mortality in this group of patients. So we summarized some key findings. There were no significant differences in outcomes. The risk of early reinfection was higher in the graft removal group, and the risk of late reinfection was higher in the graft preservation group. Predictors of mortality were radiosurgery, aortobronchial, aortoesophageal fistulas, and early manifestation. Sorry. Early outcomes were comparable between both groups. ICU stay was higher in the graft removal group. You see here on this slide. You see we have shown the spectrum bacterial in our patients, and half of our patients have spectrum negative infection. We do 10 reparations due to reinfection, 4 of them with graft removal, 6 with graft preservation. You see, this is a patient with prior infection, myoplasty pectoralis muscle, and reinfection. Then we do wound therapy, myoplasty with thoracodorsal flap, and omentoplasty with good result. Hospital mortality in reoperation cases with reinfection was 40%. Follow-up survival was similar in both groups. 5 years overall survival was 45%, and predictors of mortality were radiosurgery, aortobronchial, aortoesophageal fistulas, and early manifestation. Follow-up freedom from reinfection was higher in the graft removal group, and 5-year overall freedom from reinfection was 64%. Predictors of reinfection was radiosurgery, infectious history, graft removal technique, and early infection. So take-home message of this study is graft removal technique is indicated for late infection with the preferred using of gumografts. For early infection, the combination of aggressive debridement, negative pressure wound therapy, antiseptic irrigation, and vascularized flaps with a graft sparing strategy may provide similar results of aggressive graft removal. In our study, the results of both methods were comparable. The limitations of our study are related of its small sample size, retrospective design, and variety of surgery. Thank you very much for your attention.
Thank you very much. We have time for one quick question.
One question, please. Edward, it was a great presentation. Thank you. And you mentioned that in the early graft infection, you prefer to preserve the graft, and the late graft infection, you prefer to then replace. Is that correct? If that's the case, so which patient group in the early infection would you remove the graft and replace it?
Thank you very much. If we have early reinfection and false aneurysm, we not do preservation graft. We do graft in situ maybe. But if we have infection of graft, but no have any aneurysms, we can do graft preservation.
Okay, so if I can then take that message on board, so all the early graft infection with no anatomical kind of complications, we should be treating them more conservatively with aggressive kind of the irrigation antibiotic therapy with the same outcome compared to surgery.
Yes, maybe yes.
Okay, Andreas, one very quick question, please, and then quick answer.
We have the experience that with bacteriophages, which we actually receive from Russia, we could increase our rate of preservation of grafts. Do you have experience with bacteriophages?
Thank you. It's very good question. No, we don't have experience with fox.
Yeah, I remember in St. Petersburg a presentation that was quite impressive from Russia. Maybe we should put some more impact on that one. Okay, thank you very much.